Okay, I think we will get started with today's ICAP Grand Rounds webinar. Um, and I am Dr. Jessica Justman. I'm the Senior Technical Director for ICAP at Columbia. Um, and I am delighted to welcome all of you to today's webinar. Let's go to the next slide, please. So we're going to be talking about the Ebola virus outbreak in the Democratic Republic of Congo, the DRC, which was first detected in May of this year and has quickly developed into a major health threat. The World Health Organization declared it a public health emergency of international concern. And as we're going to discuss, there are no current vaccines or treatments for the Bundibugyo strain of Ebola, which is the strain that's been spreading rapidly across the region. Armed conflict and geographic obstacles are also complicating the response efforts. I'll be giving a brief overview about Ebola virus disease, and then we will hear an update on the Bundibugyo outbreak in the DRC from Etien Koua, and we'll then have Dr. Mary Foote join us for a panel discussion, and I will introduce our two guests in just a moment. I want to just remind everybody that if you have questions, to use the Q&A box rather than the chat. That just makes it easier for us to find the questions. We're also making live interpretation in Spanish, Portuguese, and French available through the interpretation button, which you'll find at the bottom of your Zoom screen. And as we always do, the webinar recording and slides will be posted on the ICAP website. So let me get started with the overview. I will share my slides, so give me one moment to do that. Yes, so I'll be providing a brief overview of Ebola virus disease. In terms of the virology, Ebola is a member of the Filoviridae family. This is one of 5 families of RNA viruses that cause viral hemorrhagic fever. And I'll just mention that the name Filoviridae comes from Latin phylum, which means thread. And you can see from the image there on your upper right that the virus looks like a twisted up piece of thread. The Filoviridae are one of 5 families of RNA viruses. There are 2 species of the Filoviridae, Ebola, which is called ortho-Ebola virus, and the Marburg virus species. I mentioned the thread-like shape, which you can see on the image on your right, and that really is a reflection of how the viral protein VP40 wraps around the viral RNA. And this very flexible shape and large surface area allows the virus to latch onto and invade human cells, and it also protects the virus during budding. There are 6 known Ebola species. The one that's responsible for the largest number of outbreaks is called ortho-Ebola virus zairense. There's also the Sudanense species. The one that we're going to be talking about today is the Bundibugyo species, and then their 4th one that is known to cause human disease is ortho-Ebola virus Tyense. There are 2 non-human pathogenic species, Restonianum and Bombaliense. The one that we're going to be focusing on, of course, Bundibugyo, I think is really quite notable for having 30% of its nucleotide sequences genetically distinct from other Ebola strains. And this has affected diagnostic tests, treatments, and frankly, recognition of the outbreak. And then the other point to mention, I think many people may know, that Ebola comes from the Ebola River, which is located in northern DRC, and that was chosen after the first recognized outbreak in 1976. And you can see the general location of it there on the map. We can go to the next slide. So we talked about the 6 species of Ebola. There have been 18 countries with at least 1 case. Since 1976, there have been 48 outbreaks, again, that have been recognized since 1976, and over 34,000 people have had known confirmed infections, and over 15,400 people are known to have died since 1976. The map on your right, which comes from the CDC, shows the outbreaks by species and size since 1976, with the gray color and the white color showing whether the country has not or has had an Ebola outbreak. The size of the dots tells you the number of the cases, and then the colors are correlated to the 4 different strains, and I've put a red box around Bundibugyo virus, which is shown in yellow. And you can see with the yellow arrow the location of the Bundibugyo. There have been 2 prior outbreaks. So many, many fewer outbreaks of Bundibugyo compared to all of the Zaire strain outbreaks, which are the red dots that you see throughout the map. Next slide. Ebola is a zoonotic disease, and fruit bats are thought to be the natural reservoir. There are many different kinds of fruit bats that are involved, but here's an example of one on your right. Transmission is primarily through direct contact with infected bodily fluids or contaminated surfaces or items. This kind of transmission is amplified in healthcare settings and through burial rituals, and transmission is not thought to occur through airborne transmission or casual contact, and I can say this has been studied extensively. Another important point is that asymptomatic individuals are really not thought to be contagious, and so I have added, just for emphasis, the reverse of that, which is to say people are contagious once symptoms begin. Next slide. The incubation period for Ebola viral disease ranges from 2 to 21 days. It's typically a week or a little bit over a week. And I think it's helpful to think about the symptoms following a dry to wet pattern. So the initial dry symptoms are fever, malaise, headache, muscle aches, which unfortunately are very nonspecific and resemble malaria as well as other diseases. And this nonspecific initial presentation delays the diagnosis and allows Ebola to spread more easily. The wet symptoms begin to occur after 4 to 5 days, and these consist of primarily GI symptoms, nausea, vomiting, diarrhea, and sometimes hemorrhagic manifestations will be present. In terms of objective signs, petechial rash, coagulopathy, renal failure, and electrolyte abnormalities are really the hallmark of this kind of hemorrhagic illness. And there's often a lot of attention on the case fatality rate, and it's worth noting that it's highly dependent on the timing of diagnosis and access to supportive care and specific treatment. But with access to really optimal supportive care, the case fatality rate for Bundibugyo virus disease, or BVD, is about 30%, which of course is still very high. Next slide. There is no approved point-of-care diagnostic test at this point for Bundibugyo virus, and that, of course, is a major challenge in responding to the outbreak, and I think we'll hear more about that. GeneXpert is the platform that's most commonly used as a frontline tool it detects Ebola Zaire, but it does not detect Ebola Bundibugyo. So that has been a challenge. I believe that there is work in progress to develop the capacity for gene expert to detect Ebola Bundibugyo, but I don't believe that that's been approved yet. Reference labs are using a pan-filovirus assay, such as the Altona RealStar filovirus screen, which is a real-time PCR-based test. And there also is a near point of care Radio 1 Ebola detection kit, and that can detect Bundibugyo virus, and that is a closed platform PCR type of test. Next slide. A little bit here on treatment. I think the first thing to say is that there is no approved efficacious treatment for Ebola Bundibugyo, not in terms of a clear antiviral. So early recognition, isolation, and optimal supportive care are really the most important steps that can be taken. Convalescent plasma has been approved as a strategy by WHO for newly infected patients, and that really has been something that's been relevant for prior outbreaks. I don't believe that convalescent plasma is yet in use for the current outbreak. Then I wanted to mention what's happening with the current clinical trials. So there is a BVD-specific clinical trial that's expected to start soon through the Partners Adaptive Platform Trial. This is going to be a comparison of the experimental antibody MBP 134 and the broad-spectrum antiviral remdesivir as treatment. I won't go through the details that are on the slide. They'll be available for you later, but just to say that participants will be randomized to either the antiviral agent remdesivir, the monoclonal antibody agent MBP 134, both agents or neither, and that will be the design of the trial. There's also a clinical trial of another monoclonal antibody called maftivimab that's under consideration by WHO. This is the most potent component of the 3 antibody cocktail in Mazab, which is used to treat the Zaire strain. Next slide. And that was all about treatment. In terms of prevention, I'll first start by describing the situation with vaccines. For Ebola Zaire, there is an Ervebo vaccine, which is based on recombinant vesicular stomatitis virus, or VSV. This is not thought to be active against BVD. So the Coalition for Epidemic Preparedness Innovations is sponsoring a trial that will look at 3 different vaccines that are under development. So there'll be a modified version of the recombinant VSV vaccine that is being spearheaded by IAVI. There will be a chimpanzee adenovirus vector platform from the University of Oxford, which is similar to the approach that was used for the AstraZeneca COVID-19 vaccine. And then there's an mRNA platform from Moderna that's under development. So those will be moving forward. And then the other approach to prevention is post-exposure prophylaxis. So there's an oral antiviral agent, obeldesivir, which is to be given within 5 days of high-risk exposure with the confirmed contact. I don't believe the trial has started yet, but I think that that is expected to start soon. And then there's a second post-exposure prophylaxis, or PEP trial, sponsored by ANRS, that consists of the Ervebo vaccine plus or minus that monoclonal antibody cocktail I mentioned in Mazab. So that's a very quick description of where we are. I think our next slide is just the last slide. Please go ahead. So let's move ahead to our next speaker. And Sorry, I need to just hear. Oh, great. Dr. Etien Koua, thank you so much for joining us. If you don't mind, if you would be able to start off with just briefly introducing yourself, and then we'll really look forward to your presentation.
Thank you very much, Jessica, and I hope you can hear me well.
Yes, definitely.
My connection will go up and down. I'm speaking from Bunia in the field, so bear with me. So I'm Etien Koua. I'm the Program Area Manager for Health Emergency Intelligence and Surveillance, and also the coordinator of a Dakar Regional Emergency Hub with WHO AFO. So I'm leading the pillar, the surveillance pillar on the response to the Ebola outbreak in the DRC, Eastern DRC. Great. So would you like me to share my screen, or you have a slide? I can try to share it from here.
Please go ahead and share if you may.
Yeah.
I'm trying to share it here. Great. Okay, can you all see my screen?
Could you just put it into the slideshow presentation mode? Very good.
Perfect.
Thank you.
Here it shows it's in slideshow mode. So let me see.
Oh, no, it looks good. It looks good.
It's
Okay.
correct. It's correct.
It's good. Please go ahead.
Great. So I will go through a couple of slides to give you an update on the outbreak here in Ituri, but also in North Kivu and South Kivu. I will start with from where Jessica left it, basically to say that Ebola outbreaks in Africa have been ongoing for quite some time. We can say 50 years now. 24 major outbreaks since 1976. I think Jessica already mentioned the previous two Bundibugyo virus outbreaks, 6 Sudan virus outbreaks, and Ebola Zaire has been I've had a lot of outbreaks, which many of them have been happening in DRC as well. Of course, we all remember the largest outbreak, Ebola outbreak in 2013, 2016 in West Africa, which really had a very high number of cases, as you can see here. Use my pointer. More than 28,000 cases with more than 11,000 deaths. So now on the Bundibugyo outbreaks, the 2007 outbreak in Uganda had 149 cases, 37 deaths. And DRC in 2012, we had an outbreak with 57 cases and 29 deaths. And today, with what is ongoing, as you can see here, this is a much larger outbreak of that same stream of Ebola, with already more than 1,000 cases and 256 deaths. So we're dealing with something that we probably did not know well because it happened twice, that species of Ebola, but at a smaller scale. So we're dealing with really something more complicated, with more complexity, as Jessica described. Even for the identification, testing was quite a challenge in the very beginning. So here, just to show you where we are currently as of yesterday's situation report, which of course reports the data from the previous day, so June 21st. we have a total of 1,048 cases. The past 24 hours, we got 45 cases. We have 267 deaths. As you can see there, with 13 deaths 24 hours before the reporting. And 34 health zones have been affected, and 78 health workers have been also affected. We note some recoveries from the treatment centers, so we have currently 112 recoveries, which is really good news. On the Uganda side, although we'll focus more on DRC, but just to give a picture of the number of cases, there are 20 cases with 1 probable and 2 confirmed deaths. Well, there we also have 4 health workers, 4 work infections. And so this is really to show what happened with last 24 hours, but also the last week, to give you a better picture of the scale of the outbreak. If we look at the last 7 days, we had for the DRC a total of 246 confirmed cases with nearly 100 deaths, 98 deaths. So this really shows the scale of the outbreak, very large outbreak we're talking about. For Uganda, I think it is, as I've said, it's a smaller scale, which is actually was an importation from the DRC outbreak. So here are some other quick summary figures with the bed occupancy 84%. One of the things that we are struggling with is contact tracing. We've currently a follow-up rate of 70.8%. We are doing quite well in alert investigations in the field, but because, as you can see, we have about 8,000, more than 8,000 contacts, which of course does not represent the full contacts that we could have from this large number of cases. If we break this down by provinces, you can see that Ituri has the largest number of confirmed cases and deaths, with a CFR of 22.6, and also where we're receiving more and more alerts as well. As we can see here, that's 300 alerts, that was for 1 day. In North Kivu, 91 cases, 50 deaths. That's where we have a very high CFR, almost 55%, but also where we are having some trouble with case contact tracing as well. In South Kivu, we have 3 confirmed cases with 1 confirmed death, with a CFR of 33%. There is more in terms of breakdown, so I'll get to those. If we look at the geographic distribution, this is basically what it looks like. On your left side here, these are confirmed cases distributed across all the affected health zones. So you can see a large concentration of cases in Ituri area, and of course also in the North Kivu here. Very clearly, we can see that there's in terms of hotspots, really around Ituri, but also around the North Kivu area, with all the routes connecting different places. You can imagine how this is actually spreading across, and we're having new cases, for example, in this province, health zone right here. So overall, 34 health zones affected, as I reported. 20 of them are in Ituri province alone. This is to show quickly how the geographic spread is ongoing from one health zone when the outbreak was notified on May 15th, and slowly moving to 11 health zones some days after, to now about, all of it for 34 health zones, and in the 3 provinces in the DRC. When you actually look at this data down to health area level, we can see the concentration really around here. Aro, so Bunia health zone, but Airo health area, but also Rampara and Halo and Gualu and Bigo. These areas that have the more largest concentrations of cases. So this is actually helping us in the shaping up our interventions on the ground. And so if you look at the epidemic curve, this is really happening, and we can clearly see that there would be possible multiple peaks that will continue to happen. Obviously, you have to really not take too much of the last days reporting, because data reconciliation continues. But we're really seeing a high number of cases being reported. So this is also on the right side, showing it by weeks. So again, here I mentioned that the recent decline does not show any significant changes. This is simply because of a late reporting in some areas. I had already mentioned the breakdown by province, and we're showing that Ituri has 91% of all the cases, and North Kivu 9%. And of course, South Kivu with 3 cases that we know, and this has stayed that way for quite some time now, and we really hope this will stay like that. Again, if we look at it closer for Ituri, we have 4 health zones that really have a majority of the cases. And of course, don't mind the scale here, but this is just to make it visible, more readable. The North Kivu, we've also 3 health zones that have the largest number of cases in that province, so Koua, Butembo, and Beni. Really, this is a subset of the data at that time, because of the line list being updated as we move on. But we can clearly see the trends in each one of the 4 health zones that are most affected. So we see really that concentration over time here. And so those areas we know have a majority of cases, but we know other health zones also are important to watch as the number of cases continue to increase. If we look at the sex age distribution, we can say a few things here, that the confirmed cases are concentrated among working age adults 20 to 40 years. We also see a larger proportion of female, and we'll see in the next slide why. I think we see that many of the transmissions are happening at home. So females taking more care at home may be more exposed to the disease. And children and older adults are relatively less represented in this graphic. So I mentioned the household impact, I would call it that way. Here, with a subset of the data where the profession was properly recorded, you can see that there's a large proportion of the cases that are linked to a housewife and home makers. So that's something to also have in mind. We don't have, all the data for the professions. Sometimes it's quite grouped. As you can see, a lot of missing and no occupation also comes in there. But one important aspect is also the health worker part, which you can see representing this data set, almost 8% of all the cases. Now, on the trajectory and some forecasting that we are doing, we already projecting that by the end of this week, we'll be at around 1,200 cases. So, which means that we are really on the increased phase of the outbreak. So, we are not there yet, and we'll continue to see the rise. And hopefully this will not last too long so that we can really control. Of course, there are a lot of interventions ongoing that targeting control of the outbreak. Also, in early days of the outbreaks, we had a lot of issues, many issues on laboratory confirmation, which is being addressed. And we can see here the turnaround time being quite reduced. For example, for the Bunia area, and also quite, in the Nyankunde area. Changes have not really happened much in some areas, but there is a whole decentralization of labs, which is happening on the ground, which is going to help really reduce the turnaround time to improve quickly case management. I will say few words on alerts. So we're really seeing, increase in number of alerts across the 3 provinces. So we're seeing more alerts in North Kivu, for example. The good thing here is that we see a lot of efforts to really investigate all of those alerts. And as of yesterday, all of those alerts were investigated, which is a very good thing. One thing to note here is that many of the alerts are also about suspected deaths. So here, for example, we have 60 of the 200 suspected alerts that were actually community deaths that were reported on the 21st of June. Another area that is very critical in this response is the contact tracing. Currently for the DRC, we have 8,424 contacts, which we believe is low compared to the volume of confirmed cases. But follow-up is still very low as well, 70.8%, which we're really targeting 95%. So we are really below our target. And as we can see, it's much lower in North Kivu. And we struggle a lot with Ituri if you look at the number of contacts in that area. I will not speak about Uganda. They are doing very well in terms of contact tracing. Of course, it's a different setup with very much fewer numbers of confirmed cases and contacts. I will just go through this very quickly. This is something we have started analyzing. So just to give you a quick idea of what we are seeing in the data. This is a subset, obviously, where the data is well documented. With 250 index cases, we had about 4,000 contacts listed. We're seeing around 14.1 contacts per case, which we believe is very low. We're looking at something expected to be around 40. But on this data set, we have 91 that became suspect. Of course, I don't have a testing data here to show you how many became positive. But that's really the cascade that we are seeing. Areas like Rampala have most of the contacts. But we're also seeing that some particular patients actually have generated more contacts, and this is something we are following up. In terms of sex, we have pretty much this distribution you can see here. We don't see really big variations. The other thing to stop on the contacts is really we're seeing a lot of type of exposure that have been kind of revealed in this analysis, most of the transmissions were through physical contact, direct contact, 81%, which is really the majority. We also have some of the direct contact with body fluids, and also household people sleeping in the same bed, for example, so the couples, and things also linked to linen. And then I think there is a small proportion that goes into breastfeeding. But these are really preliminary, and we continue to look at it to understand some of the transmission patterns. Also looking at the relations of contact to the source. We're seeing, of course, mostly neighborhood, but also parents-child relation into the transmission. Let me quickly go to end on this one. There's a subset again from that list that we looked at, because it was well documented, which was about 50 source cases that generated 513 contacts. We could see clearly in that data set that there were 91% high-risk contacts. So these are individuals who had direct contact with, for example, bodies, or during funerals and things like that, that were listed. So this is very important, because we are also there will be a large proportion that will become positive, and we're also tracking that as well. So I think we are also tracking the 21-day follow-up. So far, this is actually showing that we are really still at the beginning of the outbreak, with only 7% who have completed the follow-up after 21 days. Yeah, so, and again, that's just to repeat that most of the contact are still in the early days, I would say. You can see here the concentration on day 1 of the follow-up, and fewer really ending on the 21st, day 21st. So this really tells that we are really in the beginning of the outbreak, and many people are still in the 21 days window. Also, if we look at by geography, we see clearly that some areas have highest median population. So, for example, in Aru here, where about 85% of the contact have already reached 25 days, compared to other areas where it is not the case. This was really to give you a quick overview of what we are trying to understand in terms of the contacts data. So to finish, I would say that the outbreak remains active, and it's a complex one. The priority is to break hidden transmission chains by intensifying our surveillance, contact tracing, and laboratory activities. Of course, with the late detection, we believe that there are possible hidden transmission chains, which we're trying to understand. As you could see, there's a wide geographic spread with 34 health zones represent a very large population in the DRC. I mentioned the follow-up of contact, which is below our targets of 95. And then some of those delays on the laboratory side, which are still remaining. Of course, there are some resistance, for example, in the community for swab, but these are being really addressed. A lot of misinformation that our teams on our RCC team are addressing some of those challenges on the communities. Persistent gaps in PPE, IPC, supply gaps are also still there, mainly in North Kivu. So we're moving forward. We're trying to really intensify active case finding and alert investigation, and to raise the daily contact follow-up to reach our target of 95, reduce the lab turnaround time, and clearing all the backlogs. There's probably very few that are still remaining. Reinforce RCCE, IPC, and solution and field logistics, and then also, the deployment of multidisciplinary rapid response teams to some of the key hotspots like Mungwalu, Aru, and other high-risk areas. So Ituri being the epicenter and the other high-risk areas, these are really our targets, and also strengthening the cross-border readiness with Uganda. Okay, I want to stop here, Jessica, and thank you for listening.
Wonderful. That was really fantastic to hear what's going on from you. We really appreciate it. Let me now introduce our other guest. Our other speaker is Dr. Mary Foote. Dr. Foote is an infectious disease physician who is the medical director for the Office of Emergency Preparedness and Response at the New York City Health Department. She has served on the front lines of many New York City outbreak responses, including Mpox and COVID-19 and measles, when she was in the role of Director of Healthcare System Support. So Dr. Foote, welcome. And I wanted to just, give you an opportunity to respond to what we heard just now from Dr. Etien. And then we can take some questions from the audience and from among ourselves. So please go ahead.
Thank you. And just a huge thank you to Dr. Etien and your team and all the work that you're doing. We're so grateful for everything you do. They asked me to just speak a little bit about what we're doing from the US local public health perspective in particular. And, coming from New York, we're the most populous city in the country, and of course, a major transportation hub, both globally and domestically. So, we really invest a lot in terms of our preparedness for global outbreaks. So internally, we have a 24/7 on-call line that's staffed by physicians. And so anytime we have an outbreak kind of going on internationally that looks like it could present a risk, especially with a viral hemorrhagic fever, we do, close updates of our protocols. But more importantly, a lot of these on-call doctors are not as well versed in these, infectious diseases and some of the epi risks. So we do a lot of education with our providers on just, what are you looking for if you get one of these calls, what questions to ask, how do you assess them, appropriately, and how to escalate. Very importantly, we have subject matter experts that we really encourage, them to leverage. Another core function of public health is that we do a lot of the lab testing for these high consequence infectious diseases, since it's, very rare. We have capabilities through the BioFire panel. It's a global fever special pathogen, so we can test for a very broad array of viral hemorrhagic fevers, in particular, all the Ebola strains. And so we're a reference lab for the city, and we can help arrange testing at the CDC if we can't do it ourselves. And then right now, you may be aware that the US has decided to do what they call traveler funneling. And so people returning from DRC, Uganda, and South Sudan, and right now that unfortunately is only US passport holders, US citizens that can return. But we are then funneling them through 4 different airports in the US, including JFK, which is in New York City. And so there are teams there that do the initial screening when somebody arrives from one of these countries looking for symptoms. They collect all their contact information and then send that information. The CDC sends that information to the jurisdictions where the people are going to be returning. So we get a list of travelers every day. We do an intake, do a thorough risk assessment, and then we complete monitoring based on their, we have a monitoring protocol based on their potential risk of exposure. And so, that's for the 21-day period. And right now we have a text-based monitoring system. And if somebody reports the symptoms, then we have protocols, how to escalate this. One of the main goals is to try and, really protect our healthcare system, and try and prevent as best we can to have people just showing up in an emergency department or clinic. So we give them clear instructions on what to do if they develop symptoms and who to call. And so we work very closely with our partners at the New York City Health and Hospitals, which have a virtual urgent care telehealth line. And so we have, a pathway for them to do an initial clinical assessment. And then we consult with those providers to, if somebody needs potentially just monitoring at home, great, and we'll observe them. If not, if they need testing potentially for malaria or other things, then we can do a warm handoff to the healthcare facility and, kind of do a consult with them to make sure that they're safely evaluating these patients.
Great.
And I want to leave time for questions.
Yeah, well, I was going to just say, I wanted.
Yes, so I won't go into too much more detail, but I mean, that's what we're doing kind of from our side. And then I think just really important to emphasize that we really find a lot of value in doing exercises and drills, both, with our agency, but also with our healthcare providers. So I think that's kind of really focusing on that, identify, isolate, and inform, if a patient does show up, with symptoms, how do you appropriately manage that? So we're always trying to practice and improve on that. And I'll leave time for questions. So thank you so much.
Great. Okay. Let's see. I think really this question could be for both of you, but let's start with Dr. Etien. Can you comment on the public health approach to presenting prevention strategies to the general public? What are the challenges, and what approaches seem to be the most effective? And I think we could have a whole webinar just on that. But if you can just sort of give us a brief reply from each of you, I think that would be great. Please go ahead.
Yeah, thank you very much, Jessica, and a great question. I think the number one thing in terms of prevention is really the communication aspect. So risk communication, community engagement is really key. As you know, there are some challenges in some areas here with security, but relying on the local community leaders, that aspect can actually be resolved. But the key is really how we can have a proper messaging to the population in terms of prevention measures to really reduce the risk in the communities. I'll stop here. Thank you.
Mary, a brief comment on that? Presenting prevention messages to the general public.
Yeah, and as mentioned, we have our traveler intake where we do a lot of just general education and about what to look for, how to stay safe, and what to do if you get symptoms. But fortunately, it's a very different challenge for us. Nothing like what you're dealing with, Dr. Etien. Thank you.
Okay, here I'll take another. This is a question that has come in specifically for Dr. Etien. I know, and I wondered it myself, you showed some data on turnaround time for the period from onset of symptoms to the return of the lab results. What's your target? What are you aiming for? Are you aiming for 1 day? What's necessary?
Absolutely. This has been a very important aspect of this response. In the beginning, we were really stuck in the country had issues in having lab results quickly. So what we are looking for and what is actually happening now is really 24 hours. If we can get the result in 24 hours, that really helps take the decision quickly.
Okay. Okay, great. Let's see. I think another question I wanted to pose, and then probably we'll have to start wrapping up, is whether either of you can appreciate the impact of the change in the relationship between the United States and the World Health Organization. Has that impacted your work in a way that's noticeable?
Yeah, so for us, I think there have been even some very positive changes, I would say. Recently, I think US CDC is actually supporting the countries and also interacting with some of the teams on the ground. So this is really positive, and we hope for even better relations.
Okay.
Thank you.
Okay, great. Mary, anything on your side from that?
Yeah, that's actually very nice to hear, Dr. Etien. I would just say, kind of from the state local perspective, we have been a lot more proactive in, building relationships with international partners, kind of on our side, just to kind of have redundancy in our ability to get information and intelligence. And we do, I would say, have built much more robust communities of practice among state and local partners to kind of share our best practices when we are not always as reliant on our federal partners, let's say.
Okay. Let's squeeze in one more question. It really goes to communication and working with the community. Any comments on sort of the way to handle misinformation and community beliefs that really might delay the reporting of symptoms and the report and the seeking of care? I know there's no magic bullet. We all know that. But just tell us what your thoughts are.
Yeah, so very quickly, it's a very important aspect of the response, and I mentioned already the communication, the risk communication and community engagement, messaging, but also really working with communities to inform them. Our teams are actually doing is to work with the community leaders so they can themselves actually help on, inform the peers in the communities. So I think it's a whole network work that has to happen for the population to understand it. So it has a big impact. I'm sure you heard a lot about the incidents that happened, but it's all about misinformation and trust. So how do we build that trust is really the important piece of it.
Very important. Okay. Okay, well, we are at the top of the hour, so we are going to wrap up. Thank you both for giving such wonderful remarks and providing information that I think people are really very interested in. I meant to mention at the very beginning that PRI, which is the New York City Preparedness and Recovery Institute, is a co-sponsor of this webinar along with ICAP. And I also wanted to mention that ICAP's director, Dr. Wafa El-Sadr, had intended to join this webinar, but was called away to something very urgent. So just mentioning that. So thank you all for your attention. The recording and the slides will be posted on the ICAP website. Hey, thank you.
Sure.